Yeah, good evening all. So, Aswathy ma'am. Yeah.
Yeah, yes.
Yeah, so it's 6:30 and thank you all for joining. So today we have Dr. Aswathy madam. She's a head of the Department of Community Medicine and the session is titled Prevention of Chronic Kidney Diseases, a Public Health Perspective. So today we will be starting off our PG integration program. It's primarily focused at the PG residents at Amrita, but the link has been shared with other students also who are interested to listen to this topic. The aim is to make the students interact with experts in various departments within Amrita. And probably most of the times, the usual curriculum might miss some key topics. So through this initiative, we are trying to bring the topics to you. And hoping all of you will have a very, very informative session today. And over to Aswathy madam. Madam, you can start now.
Yeah. Thank you, Dr. Sabrish. Again, this is a wonderful initiative by our principal, Dr. Girish. And so let us see how it goes. Attendance is important, as has been mentioned to, as has been told to us. So I hope it is useful. Now this session, because the topic was kidney and genitourinary system, so I thought we could take something from a preventive aspect, which is our domain, which is the community medicine domain. So I'll quickly go through the presentation. And if you have, you may be residents from medicine, there may be residents from other disciplines, and maybe you could also add to whatever you know to this. I'll just start sharing. Yeah. So prevention of chronic kidney disease from a public health perspective. What needs to be done is the presentation today. So in the presentation, I'll take you through what is chronic kidney disease, its epidemiology, causes or risk factors, preventive strategies, and summary. So before that, it would be, there are 100 participants now. It will be good to know from which all disciplines you are there. Is it only postgraduates or are there others also?
No, ma'am. Currently, they are muted for the smooth conduct of the program. We will open up the
okay.
Voice later. They can use the chat box to share their replies.
Okay. Okay.
And we have students from both PG, UG, and also from married specialties, ma'am.
Yeah. Okay. Okay. Thank you. Yeah. Yes. So according to ICD-11, which is the International Classification of Diseases for Mortality and Morbidity Statistics 2022, chronic kidney disease is defined as a glomerular filtration rate which is less than 60 ml per minute per 1.73 meters square, or the presence of kidney damage that is present for at least 3 months. So the evidence of kidney damage could be in terms of structural abnormalities, which is diagnosed either by imaging or histology, or albuminuria above the normal level, which is 30, and urinary sediment abnormalities or other disturbances due to tubular disorders. So that is how ICD-11 classifies or defines chronic kidney disease. So chronic kidney disease is a silent killer. And who is affected? 10% of the population worldwide is affected by chronic kidney disease. And this can affect anybody from anywhere. But people who are above 75, 50% of them are affected. So which means as our life expectancy increases, we are going to have more and more people with chronic kidney disease. And already our life expectancy is increasing with the life expectancy at around 73 and 75 among men and women respectively in Kerala. And in India also, there is an increasing trend of increasing life expectancy with better medical facilities, better treatment, better access to treatment, better access to nutrition, etc. And 1 in 5 men and 1 in 4 women between the ages of 65 to 74 have CKD. So which is quite a high number. So then what are the main causes? So we thought we would address this because high blood pressure and diabetes, which are the most common chronic kidney disease causes in adults. And this is particularly very relevant for Kerala because Kerala is ahead in the epidemiological transition and is the diabetes capital of the world and has also the highest number of people, about 1 in 3 persons has high blood pressure. So often this has no symptoms and a person could lose up to 90% of their kidney function before experiencing any signs. So who is at risk? Anybody who has high blood pressure or anybody who has diabetes or with a family history of kidney disease, or if somebody is overweight, if they smoke, if they are over 50 years, and whether if you are of African, Hispanic, Aboriginal, or Asian origin. Again, perhaps from all of you sitting here, we need more studies to really say why always Asians seem to have more risk. Again, the deposition of fat in the abdomen, the pear-shaped fat, the pear-shaped body, the apple-shaped body, which all seems to point to Asians seem to be at a higher risk for everything. So maybe we need more studies on this. And if the answer is more than if yes for more than one, then there is high risk and the doctor needs to look at it. Now there are 8 golden rules to reduce the risk. And they are again simple things. Keep fit and active, have a good control of blood sugar, have a good control of blood pressure. So as we saw before, blood sugar and blood pressure are the most important causes. Eat healthy, keep your weight in check, maintain a healthy fluid intake, and over-the-counter medicines on a regular basis, analgesics and all can also cause kidney damage. And getting the kidney function tested if there is more than one risk factor. So that's just an overview of what the kidney does. So coming to the epidemiology of chronic kidney disease. So the approximate prevalence of chronic kidney disease in India is 800 per 1 million population. And the incidence of end-stage renal disease is 150 to 200 per million population. Now, why is that important, end-stage renal disease? End-stage renal disease is important because it causes a lot of burden on the individual, burden on the family, burden on the health system, because there was a recent function where the government was subsidizing for the cost of dialysis to the hospitals, so that the hospitals could provide dialysis, because every thrice a week the patient has to go get dialysis done, which is taxing on even the affluent people. And the most common cause of chronic kidney disease in population-based studies in India is diabetes. And what is more alarming is that between 1990 and 2017, we find an increase in mortality from chronic kidney disease, from 29.3% to 41.5%. And the age standardized deaths for both sexes attributable is 2.6%, and this is the same globally. So we discussed about the prevalence of chronic kidney disease, the prevalence of end-stage renal disease. Chronic kidney disease was 800 per million, whereas it was 150 to 200 per million. And that diabetes is the most common cause. And how there is an increase in mortality due to chronic kidney disease, and it is 2.6% in India as it is in the other parts of the world. Then coming to the economic burden. So as India is from a low middle income country, the economic burden is quite high. The cost of a single hemodialysis costs about costs about USD 15 to $40. And the cost of transplant in a state-run hospital is 800 to 1,000. And the cost of immunosuppression is again 350 to 400. And this can be ill afforded by the people of our country. Now, looking at the age standardized deaths. So CKD in 2022, CKD accounted for 2.73% of total deaths. And of this, 7.3% was attributable to the behavioral risk factors and the remaining to metabolic risk factors. In 2040, the projections, these are the global burden of disease forecast and visualizations for the future. And by 2040, this 2.6, which is it was 2.6% as we saw before. In 2022, it was 2.73, and by 2040, it will become 3.9. Now, as we can see, this is in 2022, CKD is this much. This is the area or the deaths due to CKD is this much, and we can see that by 2040, if the current trends continue, then the deaths are going to increase. And as I mentioned before, 46% of the CKD deaths in India is attributable to high fasting plasma glucose among both the sexes. And the risk factor attribution is 46% of the CKD is due to diabetes. So looking at the diabetes mellitus epidemiology across the various continents. Now, in Europe, there is only a 16% increase in diabetes epidemiology. In India, in the Asian countries or the Indian subcontinent, the increase is 84%. The increase in African countries is 156%. So which means this increases, and consequentially, within a number of years, the number of kidney disease patients will also increase, which means health systems have to be prepared to take care of that. Now, earlier on, health systems were mainly taking care of acute diseases. So like a patient would come with diarrhea, or a patient would come with respiratory infection. I'm talking about the primary, secondary care institutions. So once the infection is taken care of, or any other infection, maybe typhoid. So once the patient receives antibiotics on time, the patient recovers and he goes back home. He doesn't have to worry about the disease coming back. But unlike acute care, chronic diseases are a different ballgame altogether. So for chronic diseases, it is not just the individuals or the families that have to cope. The health systems also have to change to deal with chronic care. And chronic care, the complications such as chronic kidney disease are also a part of that. So diabetes is on the rise, and all the complications would also naturally increase. Similarly, so the two most common things we were discussing was diabetes, and followed closely by hypertension. So worldwide, 1 in 3 adults has high blood pressure. And then again, these are the things that we always say, healthy diet, physical activity, avoiding tobacco, avoiding harmful intake of alcohol, managing stress. Again, very easy to say, isn't it? All these things, physical activity, having at least 150 minutes of moderate activity per week, avoiding tobacco altogether. But then again, our global adult tobacco surveys are showing that there is a decrease in tobacco use, but all the same, the smokeless tobacco has still not decreased to the extent that we would want it to decrease. And having healthy diet. So as we'll see later, the causes of this globalization, the social determinants, which are more important. So how that affects healthy diet. And managing stress. All of us are running from one point to another with no time to do anything in a relaxed manner. So looking at the prevalence of hypertension in India, this is from a systematic review. So, and there is also an India Hypertension Control Initiative. So hypertension is soon turning out to be one of the most lethal diseases in India. 29% in India are hypertensive, which is, then there are 1.5 million people who die due to hypertension in Southeast Asia. And 214 million people in India, there'll be 214 million by 2025. Urban Indians, 33% are hypertensive. Rural Indians are not to be left back. 1 in 4 are hypertensive. And there are 21% of Indian men suffering from hypertension. So what are the main factors that contribute? Globalization, urbanization, aging, income, education, housing. So globalization, how does that really affect hypertension? So with globalization, the multinational companies are here with all your high salt foods, because high salt and high sugar helps in preserving the foods also. So globalization has helped to make these foods more cheap than the healthier versions, like your vegetables or fruits will anytime be more costly than these foods which are readily available. Or maybe if you look the unhealthy foods such as the parota and chicken that are cooked on the wayside eateries and which are fried so many times, they are much tastier and much cheaper than the healthier foods which may be available in the which may have to be cooked with the vegetables and with the vegetables that has to be bought from the local vendor. Similarly, urbanization, with more urbanization, there is less physical activity. You don't have to walk a long distance. You can just jump onto your vehicle and reach the place. And so all this, then aging with the advancement in medical technology, people are living longer. Life expectancy has increased. And when people live longer, all these risk factors increase. Then there is a rising income. There's a disposable income, which people so we find people when we go to our malls, Lulu Mall, if you see, there are people struggling to control their weight, but you have the money, you have to go and spend it somewhere. You go to the nearest restaurant, and that may also be the in thing to dine with your friends. So with increasing income, I'm not saying that should not be done, but what I'm saying is maybe it should also be balanced with physical activity. And probably we should make healthier choices. And that is where food labeling is gradually also coming into being in India, where you take a food item from the mall or wherever, and it will tell you how much of trans fat is there, how much of calorie is there. And the traffic signal, which was the traffic signaling system, which was used by countries like Chile, though we have not started using it. So this is a good food means it will be green in color. That is, it is a healthy food. Or if it has more trans fat and more fats in it, then it will be yellow or red, depending on the percentage. So that is again an easy way to identify. So these are all called the social determinants, and they are the real drivers. So if we can change this, and intervening here is also, you can do it with lesser resources. Whereas once the person develops high blood pressure, or once the person develops a heart attack or a stroke, you need to spend more money to take care of the patient. And he may not always come back to his original shape where he can be a normal, productive person. Now, here is a study from North Kerala on causes, comorbidities, and current status of chronic kidney disease. And their findings are similar to what the world and India have seen, that the most common cause is diabetic nephropathy, followed by hypertensive nephropathy. And the comorbidities in these few. So they studied persons who were a known chronic kidney disease and who were on palliative care. So the comorbidities among them was hypertension, diabetes, cardiovascular disease, chronic obstructive pulmonary disease, malignancies, and retinopathy. And 60.6% were on dialysis, 13.3% had undergone transplantation, mostly from private institutions. And so often you would see in the newspapers that the panchayats collect money to assist, to help such people. So this is done with the public donations. And both of these, on dialysis and on transplantation, was significantly underutilized by women. That is, women were less in these groups. Though they had some form of social security scheme, the median monthly cost of disease management amounted to 10,500, which is most of the time beyond the reach of people. So again, looking at the leading causes of death, 2016 and the projection for 2040. So let us see where CKD was. Chronic kidney disease was in the 16th position in 2016. And we can see that by 2040, it is climbing to the 5th position, which means as doctors, we need to be prepared. We need to probably have more dialysis centers. And the health system also has to plan ahead so that we can take care of such a large number of people who may develop chronic kidney disease. So at present, morbidity is measured by the Institute of Health Metrics. They use DALYs, that is disability adjusted life years. And this disability adjusted life years is the sum of years of life lost plus the years of life lived with disability. So DALY is measured by the lives that you lost. The normal expectancy, if you're born in Kerala, is 75, but you have died at the age of 65. So that is the years of life lost. That is 10 years. And then maybe at 65, I'm alive, but I am living with disability. I'm having to do dialysis. So that is what gives the DALY. So this years of life lost is a part of DALY. Now they have looked to see whether what would be the normal with the current rate, what would be the years of life lost, and then if there is a reduction of exposure, how much can be averted. So these are the years of life lost which can be averted by reducing the high body mass index. So we can see that there is a significant difference. So it is measured as a difference between the 2040 reference, the future trend based on what has been observed historically, that is based on current trends, and the 2040 beta about what can be expected if good progress is made. So the key actions for all of us are to eat healthy, to use more wholesome foods, to eat whole foods, to be physically active, to park the car as far away as possible from the mall and walk down mall or wherever you go to shop, avoid excessive weight gain, check blood glucose, and follow medical advice. I mean, this would be what you would tell your patients. And what do governments need to do? We need to create healthy environments. So there are often many studies on the built-up area for non-communicable diseases like diabetes, hypertension. Because again, with urbanization, the park, the areas where people usually go to walk, they are all swallowed up by the urban conglomerate. So you don't have areas where people can walk or cycle. There are no separate cycling pathways. So people find it difficult. Often people will say that early morning, if I go to walk, there is a dog. There are dogs, the stray dog menace and all that. So having healthy environments is very, very important. And many panchayats have also started to provide parks to people so that people can go and walk there in the during the evenings. Then better diagnosis and treatment, this is happening. There are a lot of advances. There are point of care devices with which we can diagnose the complications or diagnose the disease early, like diabetes or hypertension. And then we need better data. better data. So it is with all of you to have better data. That is in the sense to inculcate research in your daily practice, in your daily routine, to improve documentation, so that from our records itself, you can get data which you can use, which you can, that is, we can have learning systems. Learning systems in the sense the data is there, the data is entered, it is documented well. So when you look at a small part of the data, you know that this is what is wrong and this is what you need to change. So that is a learning health system or a learning hospital system. So then you know that if you had maybe two other two other variables, you could perhaps have better controlled for the health condition. So then you add that. So that is, it is an iterative process where you go on improving. So for chronic disease, what would a surveillance system look like? So normal people can be studied through population-based studies, and increased risk of diseases. Those who are at increased risk, they'll always go to the hospital. So sentinel surveillance at the hospital. And once the damage has been done, so the patient will be more frequently coming to the hospital. So hospital discharge and health center discharges. Then among people with reduced GFR, again, hospital and health center discharges will be helpful, so that we can monitor the progress of the course of the disease. And if there is kidney failure, again, dialysis, transplant registries can be created, which will again give us valuable information. And if death occurs because of the kidney disease, then we can have a mortality database to study the age at which people are dying. And maybe we could also look at whether it is men who are dying or women who are dying. And accordingly, if we make changes here, and if we make changes here, then we'll be able to change this. We'll be able to see how the deaths reduce, and how maybe the deaths, if we are effective in what we do, we could probably see that the deaths are occurring at later ages, which would again be a success. So this is again a chronic kidney disease surveillance system, which is suggested by the World Health Organization. So to summarize, we learned about the epidemiology of chronic disease, learned about what is chronic kidney disease, the epidemiology of chronic kidney disease, how the rates are definitely rising from 2.6% of total deaths to 3.7% of the total deaths. And we also learned about the prevalence of chronic kidney disease, which is about 800 per 1 million population, and the end-stage renal disease, which is about 150 to 200. Again, end-stage renal disease means more and more people requiring dialysis or transplantation and otherwise. And then we also saw that diabetes was the main cause of nephropathy. And we also saw that that was closely followed by hypertension. So then we saw the projections by the Institute of Health Metrics, which told us how the years of life lost could be reduced by controlling all the risk factors are known. There is nothing new there. We know physical activity is good. We need at least 150 minutes of moderate physical activity. We know we need to eat healthy food. We know those social determinants are important. Social determinants like urbanization, globalization, where countries need to act together. For tobacco, there is a framework convention of tobacco control, which our country has also ratified. So under that, a number of steps need to be taken, a lot of which our country has taken. But even then, there are miles to go in terms of mapping, in terms of encouraging a healthy diet, in terms of having a good built environment, in the sense that there should be places for people to walk, where in other more advanced countries who have who are seeing a decrease in diabetes. We saw Europe only has a 15% increase in diabetes. So countries like them, they have cycling pathways, they have walkways, but our roads are mostly taken up by vehicles, by motorized vehicles. And we have a fancy for all the new vehicles. So even though we use vehicles, maybe we should park far away. So such small things, again, that is also related to climate change. So such small steps will help us to control all these behavioral risk factors such as diet, physical activity. Then, of course, early detection of diabetes, early detection of hypertension, and a history of family history of chronic kidney disease. Again, the people need to be aware that they have to visit the doctor and get their renal function or whatever as is advised by the doctor done. So that is about it. If there are any questions or comments, or if you can add to whatever I have said.
Thank you, ma'am, for such an informative session, as you touched upon the various preventive aspects and also bringing in a public health perspective. In your session, you also mentioned about the importance of data and also learning health systems also. And I would request all the residents who, if at all anybody has any interest in doing any studies in CKD based upon more of a public health perspective, there were insights which could help them in this talk. So that was also an added point. Now I'll request any of you who has any questions to. Yeah, now you're able to unmute yourself. So if anybody has any question, they can unmute and ask the questions or share it in the chat. We'll wait for 1 or 2 minutes, and if there are no questions, we will call today.
Yes, Anjana, do you have a question?
Any questions? We'll wait for a minute.
Yeah, okay.
Okay. Okay, then. Thank you, madam, for that session. And we will also have this session recorded and will be made available to the students. Thank you.
Okay.
Thank you, ma'am.
Thank you. Thank you, everybody.
Yeah. Thank you all for joining.